So I wanted to introduce a true bone doctor who's going to speak next, Dr. Alon Antebi. He's our trauma fellowship trained orthopedic surgeon specializing in pelvic and acetabulum fractures and total joints. He pioneered the anterior approach when no one was doing it in the Antelope Valley, and spent time in training and improving that technique to allow that patients to not have to travel. At that time, it was 2 hours or more. On top of that, he is the trauma and orthopedic medical director of Antelope Valley Medical Center, and he's the trauma orthopedic director of Providence Holy Cross. That is the second busiest trauma Providence hospital in the state of California. He and Dr. Sherfy were on their 2023 and 2024 mass mailer. It went out to around 120,000 homes. And this is the 2023 issue. There was a 2024 issue that also went out. He'll be talking today about hip replacement and the new technologies in his training.
Good morning, everyone. None of us would really be up here without you guys. We are in the business of pain. A lot of us went to training to learn how to get people out of pain. I also want to thank my colleagues who I've been in practice now for 10 years. I've been in practice myself here for 20 years, but then started to recruit help because I knew that this valley was growing exponentially. Dr. Sherfy joined us. Dr. Thomas Nasser and we started the practice 20 years ago this month. Hard to believe. 20 years of being in the Antelope Valley. Most doctors, when they come into practice, they want to settle in a town and they want to give the care that they were taught to give in the community that they reside in. I can tell you that a lot of us have colleagues that have been in practice in whatever town, and then 4 or 5 years later, they have to move for whatever reason. Either they didn't like the practice, or they didn't like the town, or they didn't like the hospital, for whatever it is. You know, we've been here for 20 years and have not moved and not planning to move. And we're just growing and growing. And it's all because of you guys. It's all because of the trust that you guys put in us to take care of you. You know, AVORS, our group, is the only group that takes care of both hospitals. That's it. So if you go home today and you get in a car accident and you break something, one of us is going to take care of you. There is nobody else in town that will do that. We're the only ones. When I moved here 20 years ago, first of all, I'm white. Second of all, I'm a DO. A lot of you guys know the difference between an MD and a DO. And most of us are DOs. Jewish. Completely not what was in town here. And when I moved here into town, there were a lot of other orthopedic surgeons that I had to compete with. And slowly but surely, you start to build a reputation. And I always say, when I take call and take care of somebody with a broken hip or a broken ankle, and you do a good job and you get them restored and you get them fixed and you get them back to their life, they're like your walking billboard. They really are. Next thing you know, when their hip hurts or their ankle hurts or whatever it is, they keep coming back. And that's how we were able to build the reputation and the patient volume. And when you guys are sitting in that AVORS waiting room, like, oh my gosh, when am I going to see the doctor? Not only that, but most of our doctors know that when you go to Kaiser, if you're a Kaiser orthopedic surgeon, if you're seeing 30 patients in a day, if you try to give them one more patient, they're going to complain. I don't want to see 31, right? In our practice, each one of our providers, so you don't have to wait 3 months to see us, will see between 80 to 120 patients a day. That's why that waiting room is so full, because we don't want to say no to you guys. We want to see you, we want to help you, and we want to take care of you. I moved here in 2005. In 2007 is when I started learning this anterior hip replacement. Dr. Sherfy and I, we trained at the same hospital in Michigan. We didn't even know what the anterior approach was because we learned it a certain way on how to fix a hip replacement. And we learned from our predecessors because that's the way they learned. And one of the biggest reasons I performed the anterior hip replacement is because it's truly a minimally invasive procedure. That's number one. But the main reason why I learned it initially, because initially when I started doing the surgery, the incisions were a little bit bigger. But the reason why I wanted to do the anterior hip replacement is because of what we call the dislocation rate. So one of the fears of having your hip replaced is the hip popping out of socket. There's probably some people in here that it's happened to. And it's a very, very painful ordeal to go through because your automatic trip to the emergency room, automatic some kind of procedure in the emergency room where they try to pop you back in. Even in our practice, when I was doing my hip replacements, and Dr. Sherfy and anybody else in this room, our surgeons who do hip replacements have had hips that pop out of place. And it's devastating. And once it pops out once, it can happen again. In 2007, the anterior hip replacement kind of getting in the know. And there was a very famous orthopedic surgeon down in the valley who was offering the course on how to perform the surgery. And you're literally practicing on a cadaver. And when I took that course in 2007, I came back to the CEO of the hospital, who is actually our CEO here now at Antelope Valley Hospital. And I said, Ed, this is the future, and I need the equipment to be able to do this. And that equipment, just the table itself, I don't know if any of you, if I replaced your hip, if you remember what the table looks like in that operating room, but we're looking at about a $200,000 item. And when you start getting busy and you're flipping rooms, you need 2 or 3 of them. So that's a major, major investment for the hospital, not to mention now that we have robotics and now that we have, updated implants, all this stuff is technology and it equates to money for the hospital. And for the hospital to believe in a group or in a surgeon to be able to do this is a major investment. So when I started the procedure here at Antelope Valley Hospital in 2007, it was then that other hospitals that I was going to, they're like, oh, we want you to come do the anterior hip replacement here. So it was at Henry Mayo Hospital, at Palmdale Regional Hospital, and at Holy Cross Hospital. And all those hospitals started to buy the equipment because they knew how important it was for the community to be able to do this procedure. I never looked back. As orthopedic surgeons, during our training and residency, we are taught to do literally hundreds of different types of procedures. No fracture is the same. No patient is the same. Small, large, tall, short. It's a different operation each time when you're dealing with different patient population, not to mention the different types of procedures that we do. I get this asked often by my patients. Doctor, if there was one operation that you could do for the rest of your career and stop doing everything else, what would it be? And I would have to say it would be the anterior hip replacement. How many people in this room, and not just my patients, but how many people in this room have had a joint replaced? Is it pretty much the whole room? Some kind of joint replacement. Has anybody in this room had more than 2 joints? 3 joints? 4 joints? 5 joints. I remember when I did this last time, we had, I think, somebody with either 5 or 6 joints. So 2 shoulders, 2 knees, and 2 hips. That's the other thing. It's like you do good work and people come back. Good news travels fast, but bad news travels a lot faster. If you're, a poor doctor, you don't get good outcomes, et cetera, it's kind of like going to a restaurant, right? When the food's good, you're like, yeah, food's good, let's walk out. But when that food's bad, you're going on Yelp and you're giving a bad review. We pride ourselves in trying to provide good work and good service.
You gave my life back.
Thank you. Thank you. We'll briefly go over the hip. I don't want to bore you guys with all the details. So our hip, when somebody has, like Dr. Sherfy was talking about, putting that little balloon thing in the shoulder to kind of provide a space, that's all good and dandy and it'll help your pain, but you don't walk on your shoulders. You walk on your knees and your hips. And there's really no alternative for anything like that for a knee, an ankle, or a hip because it's a weight-bearing joint. When somebody has like a knee problem, okay, we can easily give, an injection to a knee, put some ice on it, put an ACE wrap on it, voodoo, whatever, cream, whatever you want to do on it, right? But when you have a hip problem, you are absolutely miserable. There's nothing you can do. You can't put a wrap on it. You can't put cream on it because it's so deep. You're just disabled. And I say this all the time. Pain will make you do some crazy things, like come into our office and get sliced and diced and get a hip replacement. Crazy, right? Sometimes I say if a Martian came from outer space and looked in the operating room to see what we do, the carpentry that we do in the operating room, it's unbelievable. It's insane what we do. Hammers, saws, drills. We're literally like human carpenters. So the hip anatomy, it's a ball and socket. It's one of the largest joints in the body. And it's estimated that over 70 million people in our country, and it's probably even more now, have some form of arthritis. The most common, people ask all the time, doctor, what kind of arthritis do I have? The most common arthritis is osteoarthritis. And what is osteoarthritis? It's the wear and tear of your joint. It's just like the tires on your car, right? They don't last forever. You drive them enough and you got to replace them. And some tires wear out unevenly where the rest of the tire is good, but the inside tread is worn out more than the outside tread. And eventually the tire blows and you got to get a new tire. And it's the same thing with our joints. Our joints wear out. Not every joint is created equal. So when you are born, you have all these joints, but the hip in particular is known to sometimes not form correctly. And you could actually have one that's formed correctly and one that's not formed correctly in the same person. So it's kind of like, I always give the analogy to my patients, kind of like the drunk guy that was working at the tire factory, mounting the tire on the car. He was drinking the night before. The tire looks great, but when he mounted it on the wheel, it just wasn't rotating right on the one tire, and that tire is going to wear out early. And this is what happens to our joints, and particularly the hip. Rheumatoid arthritis is another common form of what we call inflammatory arthritis, where your body actually attacks its joints, and that can cause hip pain. Avascular necrosis, I know there's a couple of patients here in our room that are young. I just replaced a hip on a 21-year-old female who had avascular necrosis from a condition called sickle cell anemia, which is very common in African American population. So avascular necrosis is a very common condition that can happen to any age group where there is lack of blood supply to the head dies, the cartilage collapses, and then you start having pain. And there's multiple different causes: sickle cell, steroids, alcohol abuse. There are some people that can drink their whole life and never get AVN, and there's some people who just have 2 cocktails and we can blame it on that years later. So we really never know. Post-traumatic arthritis, for all the athletes out here or the people who have been in car accidents where your hip popped out of the socket or you broke your hip socket when you were younger, eventually that socket is going to wear out, that head's going to wear out, and you're going to develop arthritis in that hip. And like we talked about earlier, congenital hip dysplasia, basically you're born with a malformed hip that can wear out early. So you can see on the picture here that what a healthy looking hip is. The nice pink stuff is the cartilage or the padding or the cushion in the hip. A diseased hip is when that cushion wears away. It exposes the bone ends, causes a lot of inflammation, pain, swelling in the joint, and next thing you know, you got a limp, you got pain, you can't get in and out of a car, you can't stand up to go to the bathroom, and it becomes very disabling. So the way that we diagnose this is very simple. And a lot of patients are like, well, I want an MRI. I'm like, well, you don't really need an MRI. If you have advanced arthritis of your joint, whether it's a knee, a shoulder, or a hip, an X-ray is all we need. And you can see the disease process is very evident on an X-ray. Now, if I'm seeing somebody, whether young or old, with a normal looking hip and they have hip pain and the X-rays look normal, that's when I go to the MRI. And the most common reason why we would order an MRI for somebody's hip is because we want to look at the internal contents of the hip. There's a bunch of different things that can cause hip pain that we cannot see on an X-ray. Sometimes CT scans can help as well, especially if there's trauma. It can help us look for fractures that we can't necessarily see on an X-ray. So we'll order a CAT scan. Some of you may have pacemakers and other devices within you where we cannot order MRI. That's when CT scan is also helpful as well. So how do we assess your pain? Well, first of all, you come into our office and I'm having hip pain. And the first thing I usually have you do is have you stand up and show me where your hip pain is. And sometimes people complain of pain and they point to their buttocks area, which is kind of like a rare area for actual arthritis of the hip to hurt. It can transmit the pain to your back, but most of the time when people have hip pain, they usually point to their groin or the front or the side of the hip. Usually back pain the pain is distributed differently, and that's usually coming from your back. And we know because I'll get the X-ray of your hip and I'm like, your hip looks normal. It's not your hip, it's your back. Usually people come in, they're like, you know what, I can't do my activities of daily living anymore. I'm in too much pain. I can't go on the walks that I want to. I can't go to the bathroom without pain. And that usually will drive you to come into the office. Treatment options include medications. Most of the time when patients come into the office, they've already tried medication. Their primary care doctor may have already given them the Tylenol or the Percocet or the ibuprofen or whatever it is to try to help the pain. And sometimes you're just exhausted with taking these medications. We offer also injections, as Dr. Sherfy talked about, with the steroids, plasma. We offer stem cell injections, plasma injections, and anything and everything possible to help you prolong and keep your own hip before we go to metal and plastic. Most patients that come into the office have already had the hip injections. Sometimes it's their first time coming to the office where they didn't even know it's arthritis of the hip, and then I'll offer them an injection. But I tell them it's typically a temporizing thing. Again, this is a weight-bearing joint. It's not a shoulder. So that hip is going to keep getting pummeled with you walking, using it, and eventually those medications are going to wear out. Sometimes we have to resort to walking aids, a cane or a walker, because it becomes so painful. How many patients have I had come to the office and they're like 60 and they're absolutely crippled with hip arthritis and they're hunched over and they can't walk? And when I see somebody like that and I tell them, I'm going to make you better. I'm going to have you get rid of this walker where you can walk normal and stand up straight and get rid of this grandma walker that you're walking with at 60 years old. Because they really, they're 60, but they look like they're 50, but they're walking like they're 80. So when I see patients like that, it's like I thrive on that. I'm like, when they come and see me and they're like, after 2 hip replacements, it's incredible what these patients are doing after surgery. So injections is an option. Physical therapy. Sometimes patients are like, physical therapy, I don't need it. It's actually good because you're strengthening the muscles that control the anatomy. You're strengthening the ligaments and the tendons and the muscles. So after your hip surgery, if you end up needing it, you're just going to be that much better after the operation. And let's call the elephant in the room, the weight loss, right? Weight gain or heavy people doesn't cause their arthritis, but it accentuates it. So our bones and our joints are only designed to hold so much weight. It's kind of like, again, the analogy, right? You have a pickup truck and you got 4 tires on it, but now you put 2,000 pounds of brakes in the back. Those tires are just going to wear out sooner. The motor, the engine, the car is having to work overtime to carry that weight. So weight loss is important. There are some doctors, especially down below, there's these doctors that are like, you know what? You need to go lose 100 pounds before I operate on you. I feel for patients like that because they're in so much pain that they just can't function. So I try to strike a deal with them and I'm like, listen, lose 5 pounds from now until your next office. Show me that you're trying. Show me something. I try to talk to them about diet, fitness, their habits. And if they come back, a month later and they're down 5 pounds, 10 pounds, I'll replace their hip. I'll give it to them because I know that's something that they want and I know it's something that they're going to continue to do once we replace their joint. And obviously surgery is typically the last option. Now, most patients that come to the office that are like bone on bone, they've been suffering for arthritis for years and they've already had everything done. They've tried the medicines, therapy, injections, voodoo, acupuncture, chiropractic. They've tried everything. And they're just like, doc, can you do me tomorrow? I'm ready. You know those patients already. Like I said before, pain will make people do some crazy things like carpentry to your hip. Hip replacement, this is what it looks like, right? So what we do is we remove the bad ball, we grind down the bad socket, we put in, and you can see what these implants look like up here. We put in what's called a cup. I typically use screws to help fasten the cup a little stronger to provide more immediate stability. And then we put in what's called a plastic liner. It's kind of almost like your new cartilage, if you will. And the ball, and then the stem is what we put inside the femur or the shank to try to help the ball stay in place, and that's what holds your hip together. So when we do the surgery, we're replacing the bone and resurfacing the bone, but it's still your muscles, tendons, and ligaments that are doing the work. And that's why some people recover quicker than others. I don't know if she's here, but I have some patients that, I'll replace their hip, both of their hips at the same time. And literally within a couple of weeks, they're walking to the office like nothing ever happened to them. These people are typically in very good shape. They exercise, they do a lot of weightlifting, even with their arthritic joints. And that's the difference between somebody who's like somebody mentioned here earlier, a couch potato, right? Who just hurts going to the bathroom. They do no form of exercise, but they're in pain. They're going to take a little bit longer to recuperate and use their assisted device a little bit longer after the surgery. So there's close to about 275,000 hip replaced each year. It's a very common procedure, as well as like knee replacements are very common. And that's what we do. We replace the damaged cartilage and we restore mobility. That's our goal as surgeons, is to get you up and moving, get your life back, get your mobility back, and get rid of your pain. So as we talked about before, the anterior versus other approaches. So the reason why I started the anterior hip replacement, my number one reason was because of dislocations and the restrictions that most surgeons give you after the surgery, right? Because their fear is that you're going to pop out of place, because most surgeons still in this country do what's called the posterior or the lateral hip approach, and they have to cut through the biggest muscles in your body. Even if they do it through a small incision, they still have to cut through 3 to 4 layers of muscle to get to that hip joint. And with that comes restrictions. Don't cross your legs, don't bend over. And even to this day, when I do my anterior hip replacement and the patients go home and the physical therapist comes to the house and they're like, well, don't cross your legs and don't do this and don't do that. And I tell my patients, you have absolutely no restrictions. So don't listen to those therapists, okay? The only restriction you have is don't fall. That's it. Otherwise, you can sleep any way you want, roll your legs, have sex, the whole thing, right? Whatever you want to do. So that's why I do the anterior hip replacement. And it's called the direct hip replacement, because usually no matter how skinny or how obese a patient is, the direct anterior approach is literally a 30-second dissection for me until I'm in your hip capsule. I mean, until I'm looking at your joint. When you're doing the posterior approach, it'll take a good surgeon sometimes 10, 15 minutes to get to like the anatomy of where he needs to be. For me, it's literally less than a minute, and I'm looking at your hip joint. So and no matter how big you are, the incision still stays small. So this is the table that we use. It looks like some kind of torture device, right? You're basically laying on this table and you're in what's called a supine position. So you're laying on your back. Most doctors who do the posterior hip replacement, they do the procedure you laying on your side. Here you're laying on your back. And the reason why we want you on your back is, one, because that's the way we do the procedure, but the other reason is we can bring in what's called live x-ray or live fluoroscopy, where we can actually look at the anatomy, look at your x-ray, look at your what we call the leg links, the position of the implants of when we put it in. It's very difficult to do that when you're laying on your side, because sometimes the table won't allow for the x-ray machine, or the surgeon will have to take a break and then bring in a real x-ray to shoot a film and then have to wait and get it processed. And it's not, in my opinion, not as accurate when you do the posterior hip replacement versus the anterior. So this is the table that allows us to do that. So who is a candidate for hip replacement? Most of you have had a hip replacement. You know, you have to have pain, you have to have the x-rays, right? So I have some patients that come to the office and they have bad looking x-rays, but very little pain. You're not ripe for the picking yet. You have to have both, right? There are some patients that come in with almost normal looking x-rays, but not a lot of arthritis. They're not ready for a replacement either. So you have to have both. You have to have the arthritis on the x-ray and pain. And obviously with that comes your daily living, your activities. You can't do the things that you want to do that you're used to doing. We're carpenters, right? We're not cardiologists, we're not family doctors, we're not internal medicine doctors. We know a little bit about a lot when it comes to those other things. So we send you to the professionals to have you see your primary care doctors, because with your arthritis of your hip, a lot of you guys have a lot of other medical conditions, heart problems, lung problems, smoking, diabetes, hypertension. And we want to make sure that before we put you on the table, that you are as optimized as possible. I literally had a patient came in, and I haven't seen him in 5 years. He's like, doctor, you saved my life. I'm like, what do you mean? And he's like, I came in to see you for a hip replacement. Little did I know that when I went to get the blood work done that was necessary, they diagnosed me with leukemia that I didn't even know I had. People in general don't like to see doctors, but it forces you to go get some blood work done. A lot of times we pick up things that we wouldn't otherwise know. So that's important. We need to get you cleared for surgery, medically optimized before you undergo surgery. What happens after you have your hip replacement? You know, in the last 20 years, somebody would have a hip replacement or knee replacement, they're in the hospital 4 to 5 days, automatic. We knew, because we would have to round on them, change their bandages, hear about their bellyache and of all the pain that they were having. Things have completely changed. Now, 75 to 80% of the patients that we do replacements on, whether it's a shoulder, a knee, or a hip, or an ankle, you go home the same day. And a lot of that is because, one, is because anesthesia has become so much better. 2, the regional blocks that they do and we do, meaning the pain medicine that we inject around the joint, helps so much that you really wake up with very little to no pain. And 3, the incisions that we make, the minimally invasive nature of the procedures that we do, very little muscle cutting, tiny incisions, make it so you can really go home the same day and start having your therapy at home. And you don't need to be in the hospital for 4 days. There's no reason. So you go home most of the time. And again, depending on the patient, body habitus, age, etc., typically use a walker for, some patients never use a walker. Some patients use a walker for up to 3 or 4 weeks. And then you progress to a cane. You get your home physical therapy. One of the things that we worry about after the hip replacement or knee replacement is blood clots, right? All patients know about that. So we have you go on a blood thinner to prevent that blood clot in your lower extremity. Typically, we just use aspirin unless you've had some form of blood clot before, and you'll go on some other medication to prevent blood clots for about 4 to 6 weeks. And then typically after the surgery, we'll see you in the office 2 weeks later, and most of the time, 9 out of 10 times, patients are, at 2 weeks, are extremely happy. Knees, not so much. I walk into a room after a knee replacement, I'm like, do you hate me yet? Because they're more painful. But the hips recover quicker, less pain, and they just love you. Potential complications after hip replacement is, our number one worry is infection, right? So we do everything we can in the operating room, including the amount of time that we operate on you in the operating room. When I do a hip replacement, it's 45 minutes. I don't want to operate on you for 3.5 hours. That exposes you to the environment, inoculation of bacteria that can cause infection. So the faster I am in doing your surgery, the better it is for you. Also, we worry about blood clots, dislocations, as we talked about, leg length discrepancy. So that's one of the other reasons why we do the anterior hip, is because there's less risk of one leg being a little longer or shorter than the other after we replace your hip. We also worry about component loosening, which can happen after time with infection or just from wear and tear, and as well as fracture. That's why I say the only thing you can't do after a hip replacement is fall, because we don't want you to break the bone around the implant. So in summary, the anterior hip replacement, in my opinion, is the most advanced, truly minimally invasive approach to perform a hip replacement. When I first started, it was about 4, 5, 6 inch incision. Now I start with about 2-inch incision, and it expands to maybe 2, maybe 3 by the time I'm done. It's really a truly muscle sparing surgery. We're not cutting any muscle, we're just moving muscle out of the way. And within less than a minute, I'm in your hip joint. And this is it. So this is my family. A lot of you I've known for, 20 years. And my beautiful wife, Mindy, who we've been together now for 10 years and married for 2. And she just started her own podcast. I got to put a plug in for this. It's called Call the Nurse. Amazing, amazing content. She's actually an ICU nurse at Holy Cross, which is where we met almost 10 years ago. So you can look up her podcast called Call the Nurse on Spotify or Apple. Amazing content. Thank you, guys.